Welcome to Frankly Speaking with Dr. Wade. This show was created for and inspired by the thousands of patients I've served. So it's time for me to speak up and speak out on their behalf. With a wide range of experts, we bring you weekly insights diving deep into topics of controversy to bust through the sugarcoating that keeps you and your family stuck in the mainstream. Hey everybody. Welcome to this week's episode. We are talking about spinal discs today, whether they be cervical disc or lumbar discs from somebody that has had a prolapse, a bulging disc, or an extruded disc. And we'll go over some definitions there. But this particular patient that brought up this question, which was fantastic and pretty common, is the previous back pain and episode that he had happened over probably 9 months ago to a year, and he is still walking around with pain. And he's tried multiple chiropractors, and he's gone through multiple medical strategies such as PT, some rehab work, and injections. And he has had one injection specifically into the disc recently, and decided to ask me if that was a good idea to have that procedure done again. My first question was, did it work in your eyes? He said, well, I did have a little pain relief. It was kind of helpful for a bit. And I said, well, that is one reason to possibly consider it again. And there are several reasons to not necessarily consider it again. And what's more shocking is, again, we're back to, did your physician, your orthopod, your GP, your PCP, did they discuss the side effects of what this is? Or did they just hand you a sheet of paper, say it's no big deal, you signed off, and boom, the procedure starts? I mean, I'm not hearing any of those details when I discuss with patients, and I'm not here to be the informed consent police, but I'm just talking about being an advocate for, if a patient goes in and they have pain or symptoms and they go to their doctor, they are trusting their doctor to do something to help them as well as maybe do right by them conservatively. The latter is not necessarily the case, as the mainstream model is specifically dealing with drugs and the interactions and or surgery. So what you're going to look at as a solution in this particular case is you got a sciatica type pain syndrome. First of all, what's sciatica? You can Google sciatica and find that it's, radicular leg pain that can be in the buttock, down into the hamstring, and the outer thigh. You're going to find variations of that. But what they're talking about is inflammation of the sciatic nerve. And the sciatic nerve is a bundle of nerves that is, your sciatic nerve is about the size of your thumb. And so when you look at what that big nerve that comes from the spine and the sacrum, the lower back and the sacrum, you're going to find a bundle of nerves. And this bundle of nerves is a confluence that creates a single nerve, and that nerve is very large in diameter, and it's subject, as it goes through these passageways between muscles and soft tissue, that there can be inflammation that results. That inflammation is very irritable, and to have irritation on a sensitive nerve like that can create some deep-seated nagging type pain. You can get some radicular pain where it shoots, it's sharp. You can get pain that throbs. It just depends on where the nerve and how the nerve is interfered with, as well as whether blood vessels are being distorted and compressed, and then you're going to get variations of those types of pains. But nonetheless, it is very uncomfortable, very discomforting, and it can be a nagging injury unless it's dealt properly. Now, there's a number of causes and sources for sciatica, and the first question I have to ask is it true sciatica? And we can determine that through a number of tests in the office. Now, every patient is different with how they present with this, but there's some general themes physiologically that you can find out and discern this is true sciatica. In other words, is it the sciatic nerve that is where the problem is, such as the piriformis or the gemellus, or different muscles, whether it's glute med or glute maximus or glute minimus syndrome? They can all mimic areas of the spine specifically, as well as the pelvis, that show sciatic type symptoms. They could be very disc generated, disc source. So it can be L5 disc problem, it can be 4, L3. It can be a combination between the SI joint, lumbar spine. And that's why it's important to understand there's either a number of causes or a single cause, but in many cases it's more than just one thing, and it could be just one disc as well. And so the real key is, what would be the solution. So for this particular gentleman, he had been dealing with this chronically, and he was pretty much giving up hope, but he thought, hey, let's try something different. Let's try you, and let's just see if it works. At this stage of the game, I am seeing the fact that it's been chronic for so long that there is some damage done, but there is some confusion about what discs can actually do. Now, historically speaking, we know that discs, first of all, back in the medical model, the belief system years ago that said the disc's not that well innervated, meaning it doesn't have great nerve supply, and that there's not a lot of blood supply to the disc. Therefore, it can't be discal generated where the pain's coming from. The pain must be coming from other areas. Well, that theory has since been shot down because the disc is very infiltrated and innervated by nerve supply as well as some vascular supply. But the real key is that the disc pressure and the osmotic pressure of the disc has a lot to do with just simple biomechanics. There are other factors that also influence the health of the disc. For example, for years we kind of went over this analogy with patients. A disc doesn't herniate for no reason. And I'll repeat that. A disc doesn't herniate for no reason. It just doesn't happen. And yet, this disc is so incredibly strong. Our discs between the vertebrae are so incredibly strong that if you took a scalpel into a live, or in this case, a live body and tissue, that you could pull that scalpel out and the disc would not leak because of its brilliant design in the annular fibers and how the body is just brilliantly made to contain that fluid within the discs. The reason discs start to herniate and break down is based on a number of factors. The health of the disc has to do with biomechanics as well as circulation, nutrition, whether the patient smokes or not, and it has to do whether we assimilate our protein. Some cases are too far gone. So the body does have this point where you reach the limitations of matter. In other words, the body cannot restore enough balance because a process has gotten so far degenerative or depleted. What we do know, and we'll talk about this in greater detail when we talk about protein absorption and protein assimilation. And I'm just going to mention this because here's a great episode you're going to want to be on to hear and understand how the macronutrients actually, you're going to read things like, oh, here's your macros and people want to talk about macros. It's like, it's called food. Food are your macros. And your macros consist of three main types: proteins, carbohydrates, and fat. So the sidebar is that the connective tissue within the body, and this was really, really huge for me to understand this from Dr. Loomis, who's the first I really heard put it in these terms. And he's not only a mentor of mine, he's an incredible visionary with our profession. So I am extremely grateful for his gifts and contributions to us, namely how he's helped me change my approach with patients. If we don't digest protein well, our connective tissue is less than adequate to sustain the stresses of life. So our connective tissue is weak as a result. Medically, they're just going to go, hey, your car broke down, your body broke down, your disc herniated. We're going to go ahead and treat that. Well, doc, why'd that happen? Well, it happens from wear and tear and age and arthritis. That answer's not good enough for me. Sorry, but I have questions. Why this disc? Why now? What about my other discs? How do I prevent those from herniating? Is this going to happen to more? What does this actually mean? Is this curable? What happens to that stuff that floated out of the disc? Where does that go? The whole focus is to treat the pain and manage that pain with either injections, a surgical knife, with painkillers, which are honestly a terrible. They are great for someone who's been in pain and they've probably managed better with some drugs like that. I get it. But it is not a long-term answer. It is not a solution to the problem. The problem is the body's inability to support itself through these structures. I've seen more herniated discs from a lack of injury or trauma than from trauma. For example, female about 10 years ago came in with 3 herniated discs. And there was a wave of literally women coming in, and she wasn't in this one, but there was a few years later, there's a wave of women coming in with multiple herniated discs. Like someone came in and then all of a sudden this referral resource of all these women with multiple neck disc and low back disc herniations came in. And I'm like, what is going on here? So that said, when multiple discs herniated in a 15-year-old with no history of trauma, what do you think is going on? Why does that happen? It's a medical phenomenon. Well, when we traced it back, this was huge in my learning and understanding, because at that time, I was managing it very biomechanically. We were adjusting, and there was a good response, but it took time, and they had to be patient, the family, mom, dad, as well as, in this case, the teenager. And I remember just beginning to use enzyme. And of course, she wanted to be playing volleyball, but couldn't. So that's one of the things that was happening. She thought she heard it playing volleyball, but there was no physical trauma. You don't just go for a dig and not strain your back, but end up with 3 herniated discs. So there was a predisposition to what was going on here, and they kind of ignored it. Why? Because we're taught in our society that if you have pain, take some ibuprofen or painkillers, and then your pain, it can subside, and therefore you've solved the problem, because that's the way society wants us to handle it. In this particular case with this 15-year-old, we started using some enzymes specifically to help, and that's right when my training was just getting my feet wet into it. And I had realized and learned that enzymes specifically that affected the disc were very instrumental in how this young lady healed. And along with adjusting, in other words, correcting the biomechanical stress to the lower back spine, her full spine, around that area as well, and then allowing her an opportunity to heal, because that's what we're focused on with an adjustment, is not trying to fix the body, quote unquote. It's allowing the body a chance to heal in men, because her body has to heal those tissues. A drug won't do it. If she did nothing, those discs, back to this gentleman as well we started with, is that his discs within about 6 months should heal and could heal and probably have healed. He does something for it or nothing. But the level of healing and the level of scar tissue is significant based on whether they are getting corrective care or not. In other words, in my experience, which is worth something in today's day and age when we talk about, is that just anecdotal? Well, my clinical experience over 25 years and my experience as a patient over the last 45 years is what allows me to have a perspective and to make judgments and understand what we can do and what we can't do with chiropractic, but what the body's capable of doing and where the body will struggle. And it doesn't mean, again, that I have all the answers, but it does give me some experience to actually understand how patients have responded in the past and how to realistically share with a patient what they're capable of given scenarios and options. So in this particular case, within about 8 weeks, she was back up and healed, and within 10 weeks, she was playing volleyball again. 3 lumbar discs that had healed up. We did it with specific nutrition and enzymes and chiropractic, and a little bit of an abstinence from activity until she was ready to do that. Too much physical activity while the body's healing only aggravates. So in this case, there's been no relapse as far as I knew, but there are 2 parts to this story. This gal's father started taking the leftover enzymes that she was on. The longest time, she was released from care, and I hadn't been seeing her again. In the uniqueness of this story, the father was like, hey, this is costing us money, but she was getting better, and it was the only thing that was getting her better. She had already tried the medical route. They had nothing for her, and her mom did not want to give her the meds and drugs. She's a young, influential teenager. Nor did they want to go surgical route, because the odds of a 15-year-old doing so well, and the fact that they still didn't have answered questions medically. So her husband sits back and watches, albeit grumbling at the financial cost of actually correcting a problem outside the mainstream allopathic methods. Nonetheless, he was disgruntled with the whole process, but yet I see him coming in the office and purchasing these enzymes for himself now. And my staff's like, yes, he's been in several times to buy these over the last 3 months. And I'm like, what? What is going on? So I literally stopped him one time as he was coming in. I just asked him, I said, hey, good to see you. How's your daughter doing? He said she's doing great. She's playing, and now she's in softball this spring or fall. So after volleyball, she was still playing sports. Everything was good. Can I ask you, why are you buying it? Is she still taking this? He said, no, I've been taking it. I finished her bottle after she got better, and I couldn't believe how much better my low back has felt as a result. And I said, so what have you noticed? And he's like, well, number one, I don't have the back pain I used to have. And number two, I can do more and my back does not go out like it used to. And the interesting thing, which we'll get to in another podcast, is going to be how this specific enzymes for spinal repair are huge. So if you have some of those challenges, again, that is an upcoming podcast, and we will be talking about protein in the macronutrient absorption and how it affects connective tissue in the body and why a stable spine requires protein assimilation. So this particular individual had taught me a huge lesson, and that was my first just getting my feet wet. From that point on, I could not help but share different alternatives with patients, whether they were ready for it or not, but at least giving them options and looking at how we can help their body not only heal and mend from the pain, but restore balance and integrity to the connective tissue that actually needs to be stable to help them function in their daily life, which is why I'm not a big fan of taking a corticosteroid injection, puncturing the disc or a facet or the dural thecal sac and interthecal space there, what's called around the dura, to get in there and then anti-inflame it with a chemical or drug. What you're not told, and what this gentleman was not told, is that that corticosteroid injection, first of all, is only a temporary fix. Secondly, it's going to dry out the joint and create a more injury-prone motor unit or disc space and soft tissue around it than prior. And thirdly, that theory is that it takes one or several shots. They last either days, or weeks, or months, and everyone's different. I think the biggest challenge I have with it is the misdirection that is represented or misleading, that the patient is just going to be fixed, that they're not part of the cause, that it's nothing of their fault or blame. And we're not talking blame or placing fault. It's talking about being accountable and responsible and understanding that that patient deserves an experience to help prevent the next disc from happening, not just a surgery that repairs this one and send them off to go herniate another one. That drives me crazy to perpetuate that irresponsibility when it's something that you could simply just educate a patient on and then they can choose. That would be like a dentist not sharing with you that brushing is going to prevent the next cavity. And I don't mean that patient always has to change something, but I'm a fan of getting to the cause of the problem, not just band-aiding that as, okay, your pain's gone, you're good to go, hit the road, Jack. I mean, that is the American way, I get it. But that's not a solution to me. That's not how I want someone to help me. If I have a problem and they can foresee that just patching it will allow my problem to get worse down the road, and I'm just putting that point off, I might be a little pissed. I mean, don't I have the right to choose whether I actually try to solve this now or wait till I have more damage later and it costs more money and has affected more of my quality of life negatively? I would really want to know that now, so then I get to help make that choice for me. And so that's why this exists, by the way. I'm here to say, look, you can do an injection if you want to do an injection, and many of you still will, and I'm okay with that. But what they're not telling you on the other side is there are risks that actually take away your ability to have a healthy disc down the road just from those corticosteroid injections. They're going to max out. They're going to say no more injections. A, it's not working. It dries out the joint. It will dry out that joint, so you lose not only disc height, you lose the ability to what's called imbibe or imbibition, which means the body, when we're lying down at night and we're resting and we're sleeping, your body is literally rehydrating the disc. It's sucking fluid back into those discs from your body, and it's regenerating your height, which is why, technically speaking, we are taller in the morning than we are when we go to bed. So yes, that's a fact. And when your body has the ability to imbibe disc fluid like that, you have a greater capacity to keep pressure off those nerves. Your body can function better. Your muscle tone is better. So all the dynamics of musculoskeletal function, moreover, healthy musculoskeletal function, require healthy nerve flow. Healthy nerve flow leads to healthy muscle tonicity, muscle tone. And muscle tonicity is what's responsible for your micromovers and the deep unconscious and other than conscious, subconscious musculoskeletal spinal stabilizing movements. They are very, very teeny muscles that actually manage how your spine moves. They're not something you think about like flexing your bicep or doing squats. Those are voluntary. muscle contractions. There's involuntary muscle contractions that are going on that you're not always aware of. So lifting your right arm above your head, as an example, we have a mechanism called feed forward. And we'll get into this in another cast as well, because we need to open up more depth with understanding how testing works to determine specific spinal areas and how we tie in organ systems with that and how you know the difference and all that. When we elevate, for example, our right arm above our head, before that movement can occur, the real trick question is, what muscle moves first to move that right arm above your head? As I teach, and I ask clinical doctors this, in many cases, still the most common answer is they're thinking about what muscles of the arm or shoulder, so the deltoid, the anterior, the posterior, the maybe it's the levators right around the neck, maybe it's the supraspinatus right above on the shoulder blade, maybe it's the whole shoulder girdle, maybe it's the anterior pec. But bottom line is they're asking, it's all the shoulder. What happens is it's the brain and the feed forward mechanism in the spine that actually creates the stability that has to fire in the spine first, in this case right around T10 through T12 in that region, that muscle group in the motor unit of the spine is firing before the arm is raised. The significance is that many will treat a shoulder problem, only treat that shoulder, such as frozen shoulder. Like I just had 2 cases come in this week with frozen shoulder. Both were referred by another woman who had frozen shoulder, who's been getting some care, and over the last 6 weeks, and she's referred them in because of her success finally that she's having. So our ability to pinpoint where the problem is and then how to actually correct where that problem's coming from upstream is the clarification. It's the distinction in the results. So in this case, when moving positionally, lifting the leg to get into the car and swinging the leg in, and we get this pain that radiates down, all those movements are important feedback as to doing detective work, like what muscles are firing when and when do you experience the pain. Great. Now we can work backwards and go, here's what's happening. It may not even be that muscle group. It can be that the body has to shift weight to lift that leg, and that anytime you shift weight to the right hip to lift the left leg, see, those movements are happening without our consciousness. It's like before I lift the arm, my spine has to stabilize my body to then move the arm. That happens in nanoseconds before you voluntarily move your arm. So for many of you, that may not make a great deal of sense. You just need to know this. If you're just a patient in lay terms, you want to just get that when you have these weird Simon Says movements or you're turning your head, there are so many other things going on that need to move properly for that to happen. And if anyone has had a whiplash injury or a head trauma or a shoulder injury, you know exactly what I'm talking about, even a back injury anywhere, because you now know that the littlest movements can stimulate pain, and you're like, oh my gosh, I can't even turn my head, or I can't look down, or I can't lift my head up. And the problem can be somewhere in the middle of the spine that's creating your inability to move your neck and head. There's so many different ways to start to language this, which we'll do over time, but that gives you a couple pieces as to how to start understanding that just because one doctor says, here's the treatment for this, and it's more invasive, and they don't tell you about the risks and ramifications, I think that's where you need to just ask better questions. And some of you are like, I don't know what questions to ask because I trust my doctor. I also get that. I encourage questions. Number one, because the relationship I have with my patients is built on trust. And when that relationship is built on trust, if something needs to shift or change, and we've established trust and communication, and they know it's their choice, and I'm simply here to help guide and or direct, this choice or that choice, or you know what? If you don't have the patience, for example, I had a gentleman come in who's very active. He was a musician, very busy guy, super type A, had basically 2 cervical herniated discs and years of degeneration. So abuse. And now, he's pretty fit guy. He's looking at, can I even play guitar anymore? Can I do this? Because I have to I can't. And I've got gigs scheduled all summer. So I said, and he was referred in by a friend of his who was a patient of mine. He said, go see Doc Wade. So I met with him, and we had met each other several months or a year earlier. So he knew who I was, and I'm like, hey, how can I help? And shared the story with me. And I said, look, I can, but this is what it's going to look like, and I'm not sure you're willing to do that. And basically we started in with a couple adjustments. He said, let's just try and see if it can work. And I think we had 2 or 3 adjustments. He got some temporary relief, and that was it. But still wasn't sleeping through the night, still wasn't willing to follow my instructions and slow down, and wasn't willing to change his schedule. And I just said, look, this is probably not your best route. You're unwilling to deviate from what you're doing. You're probably better off seeing a surgeon and trying to just cut this and solve it, because you're not going to change your lifestyle and you're not willing to follow through with what I'm asking. That's probably your best route. That is what this gentleman chose, and it was the right choice for him. So I'm not here judging or saying, he was stupid, because he's not. He's a sharp dude. That was his best route for that style of patient, and that is what I'm going to recommend. I'm not here to should on anybody as much as what are your choices, what are your options, and let patients make that educated choice. With respect to the beginning of the podcast, this gentleman that just recently asked me whether he should get an injection, I literally came back with, I don't know, let's talk about what you know about the injection and see if it's the right course of treatment for you. Is this working? How much time are you willing to give it? What do you want to see happen? Is this the route you want to go conservatively? Do you want to do both? Are you aware that what happens when you can't feel pain and you numb it out and you still go do the same things, that you're actually having the potential to injure more tissue? And is that something you want to have happen? Or are you ready to kind of face the reality of what's happening and work our way through back going to get out on the other side, which is going to be healthier function, less natural inflammation by tweaking the diet to an anti-inflammatory style, which this gentleman's already working in that paleo/keto area. So he was already looking that direction, and then we can just refine it. So ultimately, we'll see what happens. I'm not attached to the outcome, and the real goal is, am I advising him in a direction that suits his focus and his wishes? And so that's where we look at giving people choice and options and allowing them to make their best choice based on their truth. My advice would be, ask your doctor better questions. And although you may not know all those things to ask, many times you're going to get a question after you've left that interaction or that appointment. And you can certainly look up on Google and Dr. Google and come up with so many different diagnoses. But you got to look, I just researched several sites that talk about corticosteroid injections and the pros, the cons, and the side effects. And it's funny. They look at like a drug side effect, but none of them mention the loss of hydration into the disc, the inability of the disc to imbibe. And that's, they don't say disc dehydration. And they'll say, like there's anxiety, there's stomach ulcers, there's actually worse pain, there's fever, these are responses. There's headaches from some of the dural trauma from the needle. But ultimately, those are just easy side effects, man. They're just going to go away. So, and that's me, yes, being facetious as to quickly downplaying those results, and that's not cool. You're the patient. You're definitely going to get bias from a conservative standpoint from me, and you're going to get a bias medically from side of the spectrum. You're going to get a rare occurrence of referral to a chiropractor. However, it happens, and I have docs that refer to me, and I refer to them as well. But I do often find, sadly, there are many scenarios where docs still think archaically about chiropractic, like it's all violent, musculoskeletal, all-star wrestling moves, and they have no clue because they don't keep abreast to it. They don't know about activator methods. They don't know about whether it's torque. They don't know about upper cervical work. They just think archaic, and so they advise a patient as to, don't ever get adjusted based on this. And it's dogmatic, it's absolutely inaccurate, it's unfounded, and it's ignorance. And that is sad because the patient is the one that suffers. That's it. Nobody else does. I don't suffer. Your doctor doesn't suffer, but they're afraid of suffering. And that negativity and that ignorance is perpetuating your self-destruction in the healthcare model because it doesn't expand your choices, it limits them. And in many ways, medicine is trying to potentially get on board, but they don't want to give up what they can't control. The end here is that we want you to ask better questions for your doctor. We want you to understand informed consent, knowing that when you are informed of the risk, which is dehydration of the joint, that will deplete your quality of life down the road, and that has deeper ramifications as you age. That's something I think you deserve to know. And unless someone's telling you that through this vehicle, I don't see, it doesn't seem to be shared through the model that's actually delivering the injection, because I have yet to have a patient tell me that they're aware of it or they're not listening. And I think all the patients not listening, no, that's not the case. They're listening. It's not being said. And that's what I would ask more of, is that you become your own health advocate, your own health warrior as to what you have to be looking out for your health. So start there and ask the questions. What are the long-term ramifications of that injection? What happens if I don't do it? What if I tried chiropractic? Now, the ones that are in the know, that know what technique we use and how scientific it is, those are awesome referrals, because the patients like, go see so-and-so because they know what they're doing and this technique is safe. And that's it. That's fine, even though there's many chiropractic techniques that are safe. It's just that there's a lot of science to back this up. As always, I just want to thank you so much for listening to this week's episode, and I look forward to our next time. Okay, my fellow health warriors, it's time to head over to iTunes, frankly speaking, drwade.com. There, you can rate, review, and subscribe, as well as share, so more of our brothers and sisters can grow to realize their voice and their health. Speaking up means you matter. We'll see you next time. This podcast is for information purposes only. The statements and views expressed are not medical advice and are not meant to replace the medical advice of your doctor. This podcast, including Dr. Wade Ananson and his guests, disclaim responsibility for any adverse effects you may experience from the specific use of information contained herein. Opinions of guests are their own, and this podcast does not endorse and accept responsibility for the statements made by guests. This podcast does not make any representations or warranties about guests' qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services referred to herein. If you think you have a medical condition, consult a licensed physician.